In today's video, we're going to look at some very informative comments from Dr. Allan Corder. So, Dr. Allan Corder is a highly experienced, highly qualified general surgeon. You can hear him, read him here commenting on some NHS issues, and he provided an enormous amount of detailed information on the infants in Lucy's case. So that's what we're going to examine in this video. Firstly, Dr. Corder spoke about the twins, Child A and Child B, and issues around them and their care at the Cancer Chester Hospital.
And antiphospholipid syndrome is a major cause of pregnancy problems, a major cause of miscarriage in pregnancy, and is a known risk factor for pregnancies. In fact, I think although it's a relatively rare disease, it is one of the commonest causes of miscarriage in pregnancy. So the mother was looked after, I think, at Countess of Chester, but I think there were arrangements for her to go to what was described as a specialist centre in London, and for reasons which I'm not clear about, she didn't. Partly because she developed hypertension of pregnancy, which could have been an entirely predicted issue in her case, but it didn't seem that contingencies for that had been made. So anyway, she was treated for hypertension pregnancy in the Countess of Chester, and given as part of the treatment for hypertension a drug called labetalol, which is a beta blocker, which decreases the heart rate and to some extent the blood pressure. It's part of the treatment for this, I understand, and had a cesarean section at which her twins were born. It had to be done early because her hypertension was dangerous at a dangerous level, and so she had the I think it was 31 weeks or something. So it was not incredibly premature, but quite premature. The babies were non-identical twins, so it is extremely unlikely that they were monochorionic twins, actually. It is theoretically possible for them to be monochorionic, but it is very unlikely. And Mike Hall does not think that they were monochorionic, or it has no record of that. Anyway, the thing about the antiphospholipid syndrome is that the thing which causes the unusual blood clotting can be transferred from the mother to the babies, and blood tests were done at the Countess of Chester, which indicated that those antibodies had not been transferred to the babies. But anyway, baby A was not well managed. He was without any intravenous fluids for 4 hours. And then there was a bit of what appears to be not very competent interventions from the registrar on duty, who was unable to get various lines in, finally put in a long line, which was judged to be too close to the heart and was taken out. There's quite a lot of detail there. And then apparently 20 minutes after the long line was put in, oxygen levels decreased, and the sort of emergency calls put out, and a consultant did come in at that stage, but up to that time it had all been managed by juniors. And then sadly the baby died, despite efforts for resuscitation. So that was baby A. The At post-mortem, the findings were across pulmonary arteries, which in themselves are not necessarily dangerous, but can be associated with other congenital abnormalities, apparently. And the one of the points which has come up, which is important because of the allegations of air embolism, is that a pathologist specifically looked for any evidence of air embolism and found no froth in the heart. Mm. I think the pathologist may have looked carefully because of all the issues about the failure of the umbilical venous catheter and other lines going in, and wondered whether there could have been an accidental air embolus. I don't know, but anyway, the pathologist did make a note of that there was no sign of froth in the heart, also, and so no sign of air embolism. That I think it was Dr. Saladi, I think it came. Anyway, so we don't really know why that baby died. The expert witness panel thought it might have been a clotting thing, and indeed it might have been a clotting thing. I just asked people to consider that blood tests like the one for antiphospholipid, which is done on the babies, there may be other factors in the mother's blood apart from what they test for, indeed possibly unknown factors. And the antiphospholipid syndrome is not common, and there's not a huge body of literature about it. But there are some good papers, mainly from France, actually, and also meta-analyses, which do show that overall there's about a 4 times increased risk of neonatal death in babies whose mothers have had or mothers have antiphospholipid syndrome and who are successfully born. Obviously, a lot of these babies are sadly lost as miscarriages because of the underlying nature of the antiphospholipid. Yeah, and then at the trial, the gas in the large vessels, which was pointed out by Dr. Arthurs. Well, the thing that Dr. Arthur didn't say is that this is not an uncommon finding in babies, neonates that die, sadly, and there are other papers which show that to be the case. And also in the leave to appeal, the leave to appeal said, well, Dr. Arthur said that this was incredibly rare. And then they give a list of things, including sudden infant death syndrome, where it is known to occur. So it's a sort of, again, being very selective with the evidence. The other thing that Mike Hall points out about baby A is that the Evans and Bowen said that this baby was entirely stable and she was doing well. And when you look at the respiration chart, it's clearly abnormal, very abnormal. Very few normal readings within that respiration chart. The odd thing about it is the blood pressure chart remains stable, but there's a reason for that. And the reason for that is probably the beta lock, that's beta blocked. So the pulse rate of the baby is not going to go up. So none of this stuff was shown at the trial. The fact that this baby was not stable, that the respiratory rate was gradually increasing and was abnormal. This is not signs of a well baby at all. So, yeah. So yeah, completely muddy waters. Yeah.
Absolutely. So there's just a couple of follow-up questions I'd like to ask you. The first one is just to clarify something. So I have cited myself the notes about the lack of frothy blood
Yeah.
in the ventricle of the heart. Now, I just want you to confirm that is a critical sign, isn't it?
Well, I think it is because now this is not a well-studied topic, and the literature is clearly there are no experiments done on human babies. That it's sort of that doesn't happen. But the if you are to propose that an air embolus was the cause of death, surely you've got to have, and that it stopped the heart. Okay, being one of the principal definitions of death, you've got to have some evidence that there was something stopping the heart there. But if there isn't, then it surely makes it a tenuous proposition.
Yes, absolutely. The other thing I wanted to ask you as well is that when I spoke to you previously, you cited the fact that there was nothing that when you essentially were critical of the notes, saying,
Yes,
so
yes.
could you expand on that a little bit, please?
Well, as I understand it, there were no contemporary records made of an odd rash at the time. This was all um, people chatting about things, or and obviously making statements in court and this sort of thing. Now, the thing is that sadly, when anybody dies, not just babies, you can get all sorts of strange discolorations as death overtakes them, sadly. And the thing is that there's very little consistency about these descriptions throughout the trial. And throughout what some people talking about some discoloration on one side of the body, some people talking about flitting appearances, other people talking about lines of stuff. It's not a consistent story, and Xu Li himself says that really this isn't anything that convinces him that air embolism was a factor here.
Yes.
In this second clip, we then moved on to discuss Child E. Even in the Lucy Letby case, this is a particularly ridiculous example of something that should just never be in court. I can't say it's the most stupid case of the entire court case because there's Child K, of course. It's hard to say that anything other than Child K is the most stupid case, but Child E is certainly a cut and dried example of gastrointestinal hemorrhaging. So I discussed Child E further with Dr. Corder.
So let's talk about Child E. So this is a case where I can't really understand how it can conceivably be in court. Would you like to talk about that case?
Well, again, another high risk baby. All twins have an increased risk, by the way, even if they're term, slightly increased risk. Premature twins do have an increased risk. Interestingly, baby E twinned with baby F, who was the insulin baby, one of the insulin babies. Anyway, 29 weeks, so significantly premature, not too reasonable weight, um, but there had been some problems with the child. I believe there'd been some problems with the child's glucose levels. Uh, yes, had some hyperglycemia, too much glucose in the blood. And then the child collapses with blood around the mouth and then produces more more blood, basically has what we call an upper gastrointestinal hemorrhage. And the allegation was that Lucy Letby somehow caused this by instrumenting the esophagus with some sort of sharp weapon, unspecified. But according to Dowie Evans, there's lots of things that could have done it in the neonatal ward. I believe he proposed at one stage that it was a nasogastric tube, and that's a bit like trying to kill somebody with a balloon, beating them over the head with a balloon. I mean, it's just sort of ridiculous. And the defense counsel should have had fun with that. I mean, it's that ridiculous. Anyway, so the thing is that if you poke something down somebody's throat blindly, you're not necessarily likely to cause them to bleed very much. But the significant problem with that, and that's something we used to see a fair bit in the past in surgery when we used rigid esophagoscopes, was that you could perforate the esophagus, you could perforate and cause. So usually the problem was perforation and sepsis, not bleeding. To actually cause bleeding by doing that it's just not something that really happens. And the volume of this blood in the end, there was a warning signs with some, and then quite a significant amount of hemorrhage. There was very little, very late blood cross-matching to make up for any blood loss, very little of what you would normally describe as in normal adult or even pediatric practice as proper volume resuscitation. And then when the baby sadly died, the pediatrician said, to the mother, well, I don't think we really need to do a post-mortem here because it's necrotizing enterocolitis is the diagnosis. Well, there was nothing to really indicate necrotizing enterocolitis as this problem. So we have incompetent advice, and then we have no evidence. I mean, it's no post-mortem. Mother asked to make decision after decision with doctor. I mean, one of the collapses was when Dr. Harkness was actually in the room. So what, she isn't it supposed to have, what was she supposed to have done when Dr. Harkness was actually in the room? I mean, I don't know. I mean, it is extraordinary. The one of the things, the emotional things that have been cited was the mother heard the child crying in a way that she'd never heard a child cry before. But how many times has she had a premature baby? I mean, honestly, the trouble is that's the sort of thing that somebody's going to dredge out to say, oh yes, this baby cried because it was assaulted. Well, I think that's an extremely poor conclusion, actually.
So my full interview with Dr. Corder lasts for over 1 3/4 hours. I think it's particularly illustrative and interesting because he has a huge amount of specific understanding as a consultant surgeon, and so is able to go into some quite forensic detail regarding the infants. And we also discuss some general issues around Lucy's case as well. So it's certainly worthwhile checking that interview out. Tomorrow I'll be back with more highlights and discussion with another expert on a different aspect of Lucy's case, so I look forward to speaking with you then.